Title is Stress Strain and PEEP. I have no conflict of interest. So what we know about PEEP? After 25 years of several randomized control studies, the situation is this. We have 3 major studies published more than 20 years assessing high level of PEEP compared to low level of PEEP, maintaining the same tidal volume in patients with ARDS. Here are the results. So alveolar study, lab study, expert study, so performed in Europe, in Canada, and US, and the hospital mortality was not different. So based on these 3 randomized control studies, seems to be any effect to use high and low level of PEEP. But the problem is not so simple, because this was a meta-analysis by analyzing this data, looking only with patients with ARDS, so the more severe patient with the more impairment of gas exchange. And they analyze the 2 groups, high level of PEEP compared to level of PEEP. And consider only this category of patients who were treated with high level of PEEP presented a significantly lower amount of mortality. So the message of this meta-analysis is that maybe in the more sick patient, high level of PEEP should be used. However, every time we increase PEEP, we should take account the possible side effect on the hemodynamics, because by increasing the intrathoracic pressure could be a decrease in venous return, decrease in blood pressure, and splenic hypoperfusion, the possible increase of acute renal kidney, and so on. So in this study, the author not analyzing just one level of PEEP, by maintaining the same driving pressure, so the same inspiratory pressure delivered by mechanical ventilator, they adjust the level of PEEP from 0 up to 18. The idea is not to find an ideal best PEEP, so not one level, but a range. And as you can see, by moving from 8 up to 12 centimeters of water of PEEP, by changing the PEEP, the compliance of the respiratory system did not change. And again, in the right part of the slide, any change regarding the dead space and the consequence, any change regarding the alveolar minus ventilation. So the idea is not to play with, in ARDS patient with just one level of PEEP, but try to use a range of PEEP. Why this? Because by using in each patient different level of PEEP, we can maybe decrease the risk of overinflation, the risk of barotrauma, and the possible risk to increase the mechanical power, and the negative consequence on hemodynamics. So the idea is that this, what they propose, based on the found of this article and the previous data, there is not an ideal PEEP level in each patient. Maybe there is a range that we can use during mechanical ventilation. By moving from the level of PEEP, now we approach the mechanical power. The mechanical power is a new index that is available in every mechanical ventilator. And what is the mechanical power? The mechanical power is a sort of an index of the injury that is delivered at each breath by mechanical ventilator, so by setting the physician and the condition of the patient. So is the sum of interaction between the patient and the ventilator. And is linked to the mechanical characteristics of the patient, so according to the elastance of the respiratory system, the resistance of the respiratory system, and the level of PEEP. So by increasing, for example, the tidal volume, we can increase the mechanical power. By increasing the PEEP, we can again increase the mechanical power, and every time we have an increase in the respiratory system, the mechanical power is increased. But the mechanical power is obtained by the power, so that each delivered every breath, by respiratory rate. So by looking only at the power, so the possible injury, the author analyzed the different inspiratory flow. So the problem is that maybe we can obtain the same mechanical power at the end of the inspiratory volume, but during the breath can develop a different intracycle power during different, for example, inspiratory flow profile. Here is an example. So in the upper part is the elastic pressure, and then is the tidal volume or inspiratory time, from moving from the left to the right by increasing the respiratory system. So from moving from the expiratory to inspiratory phase, there is a continuous increase in the elastic pressure generated inside the mechanical power. But look what can happen for the intracycle power. At the beginning, we have a very high intracycle power that significantly decreases during the tidal volume. So the idea is to understand if possible inspiratory flow can generate different intracycle power. So they develop a mechanical analysis based on a bench test, and here is the different constant flow, deceleration flow, pressure control. The point is what was measured, and the blue line was the predicted. So the model worked very well. So the model was able to predict what happened during the inspiration. By maintaining the same tidal volume, this is in the upper part is an example in severe RDS, in the lower part, patient with moderate RDS, they analyze the different inspiratory profile. Blue is a pressure control, yellow is a constant flow during volume control ventilation, green in decelerating flow. And independent on the patient condition, the severity, what is clearly shown is the intracycle power during pressure control was significantly higher compared to the constant flow. So this, the conclusion from the author is if the idea of the physician is to reduce as much as possible the mechanical power, don't use pressure control ventilation, but use constant flow ventilation. By the next step from the same group of authors, analyzing the model with different characteristics. So for example, change the highway resistance, change the respiratory compliance, change the tidal volume and inspiratory time. And they develop again a model. They analyze, according to this model, the different inspiratory flow. And here are the results. So in the left part is the strain, so the pressure which is developed inside the inspiratory system during the inspiration. And as you can see, the decelerating flow present again a higher strain compared to the constant flow. And this, so that the decelerating flow delivered by pressure control ventilation present a higher strain was always present by changing the PEEP. So the behavior of the respiratory system was not modified by changing the PEEP. So what are the conclusion of the author? For a given compilation of flow profile and tidal volume, this can significantly affect the maximal strain, so the pressure which is generated during the inspiration. So the flow profile is a key determinant of the maximal strain. So try to clarify, you can obtain in static condition the same mechanical power. But during the inspiration, according to the inspiratory flow, you can obtain a significant intracycle power that can negatively affect maybe the outcome of the patient. Thank you very much.
Thank you very much for a concise overview of the latest literature. Again, the presentation is open for discussion and questions. Could I ask you, so you've presented various papers, including conceptual models and mathematical models for clinicians at the bedside, based on the latest evidence. Has there been any, do you have any tip as to whether there's anything they should change at the bedside at the moment?
So, first of all, I suggest to compute the mechanical power, because it's very easy. You have to perform an inspiratory static pause, and like to measure the driving pressure, and then by looking the peak inspiratory pressure, the plateau pressure, the tidal volume, the respiratory rate, there is a very easy formula that you obtain the mechanical power. And this is important because, for example, I want to reduce the tidal volume because I have a plateau pressure that, in my opinion, is too high. Of course, I reduce the driving pressure, but in the same time, to maintain the same tidal volume, the same minute ventilation, for example, I increase the respiratory rate. So if I forgot the role of respiratory rate, you can obtain the same mechanical power, but in different conditions. This is important of the mechanical power because take into account the all components that are related to the ventilator-induced lung injury. Otherwise, if you look only the tidal volume, of course, you decrease the driving pressure, but in the same time you increase the respiratory rate, you have an opposite effect. So the message is to play every time tidal volume, PEEP, respiratory rate, to use mechanical power.
Thank you very much. Any final questions for Professor Chiumello?